We'll move on to our next session on osteoporosis recent updates. I'd like to invite on stage the chairpersons for this session, Dr. Manomohan Bishwas sir, Senior Consultant Physiatrist, Nightingale and Bellevue Hospitals, and Dr. Shankar Prasad Sinha sir, Head of the Department of Physical Medicine and Rehabilitation in Peerless Hospital. I'd like to invite on stage the speaker for this session, Dr. Indrajit Sardar sir, Consultant Orthopedic Surgeon. Sir.
Thank you very much for this kind invitation to this. And it has not only been a wonderful exposition of things I didn't know or didn't realize. There are extreme advances that have been made in this discipline. And that has been a very illuminating experience. So I've been told to speak on osteoporosis and osteomalacia, especially in geriatric patients and recent advances. So osteoporosis is a systemic bone disease affecting numerous people all over the world, causing fragility fractures, especially among the elderly. In order to reach a complete diagnosis before a fragility fracture occurs, it is necessary, according to the main international guidelines, to perform a dual X-ray, absorptiometry or a DEXA to evaluate the BMD, an X-ray of the dorsal and lumbar spine, and also the fracture, also the neck of the femur, to investigate the presence of asymptomatic vertebral fractures. Laboratory tests are then conducted to exclude secondary forms of osteoporosis and draw up an accurate medical history, since several risk factors may be involved. Many drugs that permit a customized therapy nowadays is fundamental to improving treatment adherence rates, because I may prescribe many things which the patient will not adhere to. Like, for example, we often prescribe injectable daily injections of teriparatide with the 6-monthly injections of denosumab. But the problem is that people don't want to take that individual injections altogether. So in India, it is estimated that about 60 million people have osteoporosis, which is a conservative figure, I think. And a significant majority of these individuals, approximately 80%, are women, because of their hormonal structure. Women are 4 times more likely to develop than men, but men do have osteoporosis also nowadays. And osteoporosis risk climbs with age, and many women begin to develop it following menopause, but may start before that also. So having a close family member, especially a mother with osteoporosis or a history of broken bones, can increase your risk. And the whole thing in osteoporosis is that the bone becomes like this, short of with little holes in it. So thin-framed small persons have a greater risk for developing osteoporosis. This is because they have less bone to lose than people who have larger frames who carry more body weight. But body weight is also a factor in increasing osteoporosis. So some health conditions and medical procedures may make you more susceptible to osteoporosis, such as thyroid disorders, rheumatoid arthritis, because of the medicines and because of the chronic nature of the disease. HIV/AIDS, thankfully we have less of that, but not eliminated absolutely. Anorexia nervosa, which is a lifestyle disorder, and a celiac disease where people can't eat or absorb things that they should. So blood diseases like multiple myeloma or sickle cell disease can have as an after effect of this also. So in certain cases, there are some medications can cause damage to your bones and increase the osteoporosis risk. These include hormone treatments for breast or prostate cancer, steroids. Of course, the practice of giving steroids have increased nowadays, especially in general practice, where any sort of problems that arise and people are on steroids. Initially, anti-seizure medications like phenobarbital, carried on for a long time, is a chronic disease. Aluminium-containing antacids, which are consumed in voluminous numbers. Cancer therapeutic drugs. And of course, smoking and alcohol use. Smoking cigarettes can prevent your body from utilizing dietary calcium. And excessive drinking can also increase osteoporosis risk. And we know that drinking nowadays has increased to a lot of extent because of being homebound. Plus lack of exercise. Physical activity helps the bone stay strong, and leading a sedentary lifestyle can compromise your bone strength. So how is osteoporosis diagnosed? So osteoporosis diagnosis involves getting a bone density test that yields more insight about your bone health. And this test is a quick, inexpensive and painless way to determine your risk for osteoporotic fractures. It's performed using a DEXA scan, which is short for dual energy X-ray absorptiometry. The DEXA scan uses low levels of X-ray to measure the mineral content of your bone. So this bone density test of the hip and spine are done for more women who are more than 65 or older and are of menopausal age with osteoporosis risk factors, and also under the age of 65 with these risk factors. And the number of these BMD scales, BMD results are quite astounding. There is no one size fit all for treatment of osteoporosis. Rather, treating it may include a combination of medications, supplements, and lifestyle changes. Medication, if your bone density test shows T-scores of 2.5 or lower, you may be prescribed medication to strengthen your bones. There are several classes of safe, effective drugs that are approved for osteoporosis prevention and treatment. So you have hormone and hormone-related therapy. You have bisphosphonates, of which we are well aware. And of course, the new kid is the biologics, which are pretty expensive. And you have to, doing a surgical intervention has to be done between the biologics injections. And of course, the anabolic agents. So how to treat osteoporosis? So these are, some medicines are best suited to older women versus younger women with premenopause. And here a doctor will help you personally. But main thing is the dietary supplements. So you increase your intake of calcium and vitamin D. And women over 51 and older gets 1200 milligram of calcium daily, while most adults age 50 and older need 500 to 1000 milligram daily of vitamin D. You can take a multivitamin or supplements which will help you on sufficient amount of these nutrients, provided you don't get it in the diet. So if there is osteoporosis, it's important to limit alcohol and caffeine, as I said before, and avoid the use of tobacco products. Regular exercise can help slow or prevent bone loss as well as boost muscle strength, improve balance and posture, and relieve pain. So we should stick to weight-bearing activities such as walking, jogging, even dancing, and weightlifting. Be sure to ask your daughter, because you just can't go to the gym and start weightlifting. Be sure to ask your doctor before beginning an exercise regime. And nowadays we are getting more and more patients of this gym syndrome as people try to get more and more muscles, not to prevent osteoporosis, but to improve their male strength. So lifestyle changes, of course, is keeping your floors free of clutter, loose electrical cords. Mainly if you try to charge your phones and use those long cords. Using non-skid floor mats and area racks, but now the bathrooms are there with anti-skid things. Installing grab bars in the bathroom and railing on stairways. This is okay in an urban situation, but in a rural situation you can't have these. But now with more and more houses being constructed, it's best to use these grab bars. And the most sufficient is that you have sufficient lighting throughout your home. And there is a need for electricity. So keeping your outdoor areas free of clutter and in good repair, and wearing flat shoes with non-slip bottoms when you leave the house. Again, the concept of putting in a shoe is more urban than rural. So you keep your free of clutter, loose electrical cords, use non-skid floor mats and area rugs, installing grab bars in the bathrooms and railings on the sideways. And nowadays, as rural houses improve, you can use these. Sufficient lighting, of course, and keep everything in good repair. And wearing flat shoes, as I said, is more of an urban concept. Then comes the question of osteomalacia. And the reason why I booked all them together, the osteoporosis and the osteomalacia, is due to the fact that both coexist. And it's necessary for the clinical features, diagnosis and treatment of osteomalacia to be discussed in relation to recently recognized cases. This is also known as adult rickets. It is suggested the disease is not uncommon in elderly women, among whom it is liable to be confused with senile osteoporosis.
1 minute, please.
Osteomalacia may be discussed by firstly the history in which persistent skeletal pain are weakness and muscular weakness are typical of osteomalacia. You can find these deformities which are present, and of course a shuffling penguin gait suggests osteomalacia, and you can have these fractures or the milkman fractures which happen, but they're usually normal in osteoporosis, not found in osteoporosis really, but more in osteomalacia. So radiology will show diminished bone density, which is common in both diseases, but if the changes are more marked in the peripheral bones than in the skeleton, osteomalacia is suggested. Skeletal deformity without fracture suggests osteomalacia. The looser zones are present and most often found in the pelvic bones, and the most important radiological features. Finally, histology will show the presence of excess osteoid tissue in undercalcified bones. So the etiology is discussed and suggested that dietary deficiency of vitamin D, limited exposure to sunlight, and mild degrees of malabsorption may all be important either alone or in combination. One of the interesting things about is this introduction of drugs like romosozumab, which is a monoclonal antibody which will promote bone formation while inducing bone loss, either a dual action approach. You can use denosumab along with it. You can use abaloparatide with it as a parathyroid hormone, and you can use teriparatide. But then the conception of patient adherence is a big problem. So we can use personalized medicine. Advanced clinical trials focus on integrating cutting-edge technologies like artificial intelligence and genomics to develop targeted therapies. And combination therapies are sequential therapies that are multi-targeted therapies. So you can use gene therapy, and you can use lifestyle modifications like muscle exercises, walking, jogging, weight bearing, and this will prevent the resting muscle tone, which will prevent most often things like the patella not hitting on the femur bone, even due to this resting muscle tone. So high resolution computed tomography is an essential feature of finding this out, or a QCT. So do you find is the treatment working? Innovative delivery systems are now present, like transdermal microneedle delivery systems, and you can have oral anabolic therapies increasing patient adherence and reducing the treatment burdens. So effective and targeted treatment. I think this is all we can talk about the recent advances nowadays, as more and more drugs get decided upon and we get more and more things, and of course the essence of it finally will not go to it will be tackled also by physical medicine specialists, and that's the reason why we also want their help in many factors, not only in movement disorders, not only in spasticity, but also in these features of finding out whether osteoarthritis is the cause, or the osteoporosis, or any of the movement disorders or neurological problems are the cause. Thank you.
If any question?
My name is Amit. I'm a neurosurgeon.
Yes.
We deal with spine, sir. So osteoporosis is a real problem for spinal fixation, fusion, as you know. So as an orthopedic surgeon, when you will not do surgery in a patient of osteoporosis?
If osteoporosis, if a surgery involves fixing it with metals, that is the main problem, because the
Yes,
metals
sir.
just won't hold.
Yes.
So you can use things like coated implants, which
Cement
are not-
augmented screws sometimes
Yes,
we
augmented
use.
screws, especially screws and plates, which will help in finally fixing the fractures well. And that is the main reason.
Yeah, but is there a situation when you will not do surgery because of osteoporosis?
There will be, if the osteoporosis is such that a fracture has occurred without any cause whatsoever and is not fixable, not amenable to fixation, that is another problem. In which case we will try and correct the osteoporosis and then try and do the operation itself, and plus using these coated implants.
Yeah, thank you.
Thank you.
Sir, I am Indrajit. One very dumb question as a layman, sir, that that after any TKR or THR process, sir, have you encountered the problem of osteoporosis?
I think we encounter it almost every day. And our results in that post-operatively, we always use these anti-osteoporotic mechanisms, especially quick and early exercises, to get them all and about such that it helps in countering osteoporosis. One of the main reasons for doing all the TKR and all that is to get them mobile as quick as possible.
Well, thank you all. With this, we can conclude this session. Now, we can move on to next session. Thank you, sir.